questions which were submitted before. We'll go forward with Dr. Aktas presentation, who will speak to us today on the topic of use of oral contraceptives in long QT, which is also a frequent question from our prior seminars, how to deal with this daily therapy.
All right, thank you everyone for coming in on Saturday and giving me the opportunity to talk about some of the research that's ongoing. This specific topic is about the use of oral contraceptives in women with long QT syndrome. And this is a work led here by Dr. Goldenberg and the rest of the team here. And we published this in the Heart Rhythm Journal, which is our most prominent journal in the area of arrhythmia management. Dr. Goldenberg also presented this at our national meeting in 2021, I believe it was, actually 2022, at the same time that it was published. As a background, and Dr. Goldenberg already alluded to some of the things that I'm going to talk about, is that patients with congenital long QT syndrome experience arrhythmic events that may change based on where they are in their life cycle and where things are with regards to sex hormones. So, and I'll show some of the graphs that were already shown. We know, for example, that the risk changes between men and women following adolescence. This again speaks to the fact that sex hormone changes affects the way cells work, the way that the channels work, and this can then increase the risk of arrhythmia occurrence. Here again, just to show what was shown a bit earlier, is that here after adolescence, this risk reversal for serious events in patients with long QT syndrome is pretty evident here after the adolescence years. And to highlight the fact that there are significant changes in the sex hormones based on the menstrual cycle, and also as we get older, as women get older, there are significant changes during the premenopausal, perimenopausal, and postmenopausal phases with regards to levels of estrogen and progesterone. And this we have shown in this study to impact arrhythmia risk. I want to highlight one more thing that Dr. Goldenberg mentioned here. You can see that among the different subtypes of long QT syndrome, patients with long QT2 in particular seem to be very susceptible to these changes in sex hormones. Here, this was highlighted earlier that in the postpartum phase, there's an increased risk of arrhythmic events, but you can see that this risk is particularly high for patients with long QT2 syndrome. And likewise, during the perimenopausal and postmenopausal phases, patients with long QT2 seem to have a much higher risk of arrhythmic events. Now, with regards to oral contraceptives, there are several different generations. Currently available 4th generation oral contraceptives seem to have effects such that it reduces some of the protective effects of testosterone. And as a result, some of the newer agents may actually lead to QT prolongation. And we'll talk about this in a little bit. So in this study, what we wanted to do is to see if whether or not the different types of oral contraceptives, whether the levels of progesterone, estrogen, and androgen, and its effect on androgens, how that might affect arrhythmia in patients with long QT syndrome. So what we did was we basically looked at oral contraceptive use among long QT syndrome patients, and we identified those who were on estrogen only, those who were on progesterone only, and those who are on combined both estrogen and progestin oral contraceptives. And then what we wanted to do is to see how does beta blocker impact or affect the arrhythmia risk in these patients. And then, as I mentioned earlier, is this effect the same in patients with long QT 1, 2, and 3? So this was, again, from the Rochester Long QT Registry. Going back to 2010, questionnaires were sent out to women with regards to their menstruation, their pregnancy, and menopause state. And we asked them to submit these questionnaires to us on a yearly basis. And we got back approximately 1,659 women with long QT syndrome who completed this annual survey. And this is what constitutes the results of this study. Now, the endpoint we looked at included cardiac events, and this includes syncope, which means episodes of fainting. This also includes aborted cardiac arrest, meaning that patients had a dangerous arrhythmic event, but that self-terminated. This also includes long QTC related sudden cardiac death. And those patients with an ICD who received an appropriate shock were also included in this endpoint. And we had in total 1,289 patients who were not on oral contraceptives. We compared these to 370 patients who did receive oral contraceptives. I'll just break down the population here with regards to what type of oral contraceptives we're using. You can see approximately 21% of these patients were receiving estrogen-only oral contraceptive therapy. 22% were receiving progestin-only oral contraceptive, and then the remainder of the patients received a combination of both estrogen and progestin. And overall, the patients were pretty well matched with other baseline characteristics. Now, when we looked at patients who were on progestin-only oral contraceptive and compared to those who were not receiving any type of oral contraceptive, we could see that there was a 2.5-fold increased risk for having a cardiac event. And this is in the whole population. And when we looked at patients with long QT2 versus long QT1, again, a significantly higher risk that was associated with patients with long QT2 versus those with long QT1. What was notable, again, seen in many of the other studies, is that use of beta blocker therapy afforded some protection and alleviated this higher risk that was observed with use of oral contraceptive therapy that was based primarily on progestin only. And here in this graph, we can see is that patients who are taking only progestin only oral contraceptives had the highest rate of cardiac events compared to the other two types of formulations for these drugs. Now, when we looked at patients who were taking progestin only, compared them to no oral contraceptives, you could see that those who did not get a beta blocker therapy had, again, the highest risk. And this risk could be mitigated by receiving beta blocker therapy. And this is a very important take-home message that I'll try and emphasize at the end of the talk here, that beta blockers really impact outcomes in these patients. Now, this is looking at the rate of cardiac events without being on a beta blocker therapy. And you can see that there is a very high rate of cardiac events for patients on progestin-only oral contraceptives compared to the other types of formulations. And in the next slide, I'm going to show you those who are treated with a beta blocker therapy. This seems to make a big impact with regards to arrhythmic events, a 78% significant reduction, even if you're receiving, even if a woman is receiving progestin-only oral contraception. Now, as I mentioned, it appears that long QT2 patients have some of the highest risk events. And what we showed here is that this, in fact, is the case here as well for both progestin and for estrogen-only oral contraception use. But beta blockers, again, are able to reduce this risk and therefore should be highly used in patients receiving this type of therapy. In conclusion, what we show here is that progestin-only oral contraceptive therapy, patients who are receiving this formulation have a 3-fold higher risk of recurrent cardiac events. And therefore, these patients should definitely be on beta blocker therapy to reduce these types of adverse events. And furthermore, this elevated or heightened risk of arrhythmic events is predominantly seen among patients with long QT2. And so therefore, these patients probably require very close monitoring, making sure that the medications are being ordered on time and being taken on a regular basis. Furthermore, this has implications when prescribing or selecting what type of oral contraception to give, because it may be useful to know the genotype of some of these patients. And I think, therefore, this is something that will probably continue to be something we study to try and figure out what are the most effective and yet safest formulations. Now, Dr. Goldenberg already hinted to this, is that this research has implications with regards to some of the medications that we use to treat arrhythmias. For example, antiarrhythmic drugs like sotalol or Tikasin may have actions that are similar to what we see in long QT2 or long QT1. And therefore, we're going to extend these studies to try and understand how estrogen and progestin affect arrhythmia in patients who may not be affected by long QT, but may be taking medication that may prolong the QT interval. Thank you.
Thank you, Mehmet. Very informative and